to introduce Dr. Mohammed Al Kuwaiti. Dr. Al Kuwaiti is a consultant neurologist in Tawam Hospital. He has more than 13 years experience in the field of neurology and vascular neurology. He's completed his residency program from McGill University in Montreal and followed by vascular neurology fellowship from the famous University of Minnesota. It is an honor and pleasure to introduce Mohammed Al Kuwaiti, who will talk us in secondary prevention in stroke. Thank you, Dr. Kuwaiti.
Okay, again, my name is Dr. Mohammed Al Kuwaiti. I'm a neurologist at Tawam Hospital. I'd like to thank the organizing committee for inviting me for this session. I'll be presenting on cryptogenic stroke, the term ESUS, and secondary stroke prevention. Okay, I have no disclosures for this session. My objectives, I'll be defining cryptogenic stroke and the term ESUS, approach to the diagnosis and the underlying cause of cryptogenic stroke, and the potential role of atrial fibrillation, atrial cardiopathy, and PFO. And finally, I'll speak about PFO closure and new guideline regarding this. So the definition, so cryptogenic stroke is an umbrella term. It's a stroke of unknown cause. However, it takes much more, it takes lacunar stroke and non-lacunar stroke, and cases who are not completely worked up. So the term ESUS was coined around 6 years ago to specifically define embolic stroke of undetermined source, a clot that traveled and patient had a comprehensive workup. This term was coined by Dr. Hart around 7 years ago. And it includes around 25% of stroke cases are actually cryptogenic, and around half of these are ESUS. If you look at the burden and features of ESUS patients, this is a pooled analysis of cryptogenic stroke cases or ESUS patients. And actually, these patients usually have a smaller stroke, NIH of 5, a median NIH of 5. Their age is around 65. This study says 65 is actually a younger age. However, this is a Western study, so you have to take this age carefully. And usually these cases have less risk factors. And the stroke, annualized stroke risk in these cases around 4.5%, which is not that high. And looking at the workup that we do for stroke patients, I found this great article at the New England Journal of Medicine by Professor Saver, where he defines the standard evaluation of stroke patients. So as you all know, the standard evaluation is, so after history and physical, we do the regular blood workup, cardiac ECG, 24-hour Holter monitor, cardiac imaging, looking at vessels in the head and the neck. These are the basic things that we do. However, if this workup is actually negative and it cannot explain the etiology of the stroke, you can move up further to an advanced evaluation, where you can ask for a hypercoagulable workup. You can ask for a prolonged cardiac monitor for up to a month as a non-invasive recorder. And also you can try looking for signs or of vasculitis, or trying to do a transcranial Doppler to see if there's any monitoring of emboli or emboli detection. However, if still you couldn't find the cause of the stroke, there's other things you can do. For example, you can look for occult cancer. You can further look into a prolonged cardiac monitor with a loop recorder that goes up for 3 years. And you can look at the structure of the heart by doing an MRI or a CT, and trying to get probably some patients will require CSF analysis. Probably some patient will require brain biopsy. Vasculitis, for example, there's suspicion of vasculitis. And then there's genetic testing. And some PFO cases you can also do Dopplers of the lower limbs and upper limbs. And you can also can do MR venous of the pelvis. So in terms of ESUS cases, the management recommendations right now is usually aggressive medical therapy and antiplatelet. There's no enough evidence that anticoagulation is beneficial. There was recent randomized controlled trials done, Navigate ESUS and Respect ESUS. So Navigate looked into a rivaroxaban, comparing it to aspirin in patients who have ESUS. And this study was stopped early on because of no benefit, and there's a higher chance of bleeding in patients on rivaroxaban. And dabigatran also did not show a benefit over the aspirin in the Respect ESUS trial. However, looking at the sub-analysis of these trials, you'll see that the etiologies, they included patients with ESUS. However, the patients were looking at sub-analysis of different etiologies. In these cases, there were some etiologies that favored anticoagulation, for example, left atrial enlargement, for example, or left ventricular disease. And usually patients who have atherosclerosis favors more aspirin. I include this diagram because ESUS is again another umbrella term. There's a lot of different etiologies that can lead to ESUS. However, we have to try to define the etiology to be able to coin the best therapy. So as you can see here, there's examples are like atrial cardiopathy, which is a new risk factor people are looking into, and prolonged cardiac monitor to look for further like a risk of AFib, or looking at the PFO status, looking at the aortic arch or cancer. So in this slide, I have different types of cardiac monitoring to detect AFib. And if you see, it starts with the simplest one, which is the ECG. And you see the percentage of detecting AFib with a simple ECG is up to 2.7%. However, in a stroke unit where you can do a telemetry, the percentage of detecting AFib goes up higher to up to around threefold to up to 7.6%. There was a study, Embrace study, Canadian study, 16 centers, where they compared Holter monitor for 24 hours and a mobile cardiac monitor, like a patch, non-invasive one, for 30 days. And there was significant difference in detection of AFib. So it was about up to 16% if you monitor for 30 days compared to around less than 5% if you monitor for 24 hours. So it's a significant difference. And there was a Crystal AF trial looking at cardiac loop recorders where AFib detection was up to 30% if you monitor for up to 3 years. These are diagrams, these are pictures of these recorders. So this is the regular Holter monitor. This is the non-invasive patch that can go up for a month. And this is the loop recorder that goes subcutaneously. And I'm just trying to show here that patients who have a higher CHAD score and patients who are older than 70, their risk of detecting AFib is much higher the more you monitor these cases. Coming to atrial cardiopathy. So the size of the left atrium matters. So in this graph, it shows here patients who have moderate to severe left atrial enlargement. They have a higher chance of developing cryptogenic stroke, cardioembolic stroke. And there's a recent study that is still ongoing called Arcadia, and it's comparing apixaban versus aspirin in patients who have atrial cardiopathy, and is defined in this study by doing three different tests by using an echo, using the serum NT-proBNP, and looking at the ECG, trying to measure the PTFV1. Hopefully in a few years, we'll have more answers. And PFO is a common risk factor. It's actually a common finding in the community. So up to 25% of the community will have a PFO. However, PFO prevalence in patients who have ESUS is much higher. It's going to go up to 45 or even 50% in some cases. And it's actually a tug of war between interventional cardiologists and stroke neurologists in the past. What should we do with the PFO? So I hope this time we have more answers now. So this is a translogial echo with and without Valsalva, showing the the bubbles crossing into the other side from the right to left. So a PFO closure is done through a catheter, and it goes all the way up to the left atrium, and they deploy an umbrella-like structure that comes back and then sandwiches the septum, the PFO. Looks like a simple procedure. There was 3 major trials in 2012 and 13 that were actually negative. They didn't show any benefit in PFO closure versus medical therapy. And American Stroke Guideline actually in that 2014, a year later, came up saying that patients with cryptogenic stroke or TIA and PFO without evidence of DVT, the available data do not support a benefit for PFO closure. However, they only support PFO closure in patients who have risks of recurrent DVT or patients who have DVT and increased risk of another one. Later in 2017, there were 3 randomized controlled trials that were published. They were actually positive trials in PFO closure. And I won't go into detail, but these are the names of the trials and the patient number. And these are randomized prospective controlled trials, but they were open label. And looking at the data of these trials, so if you look at trials here are on the left side, and looking at the device closure versus the medical therapy, there was much less stroke in patients who had closure of the PFO compared to medical therapy. The absolute risk for recurrent stroke reduction for recurrent stroke was 3.3%. And this is a table where actually I borrowed from my colleague. It's an interesting table. You see up the first 3 rows are the negative trials, and the second 3 rows are the positive trials. I'm trying to see the difference in these trials in patient enrollment. You'll see that positive trials, they included patients who had ESUS, the ESUS embolic stroke of undetermined source, and had a complete workup. And they also looked at the same time, they looked at the anatomical variant of the PFO, looking at the shunt and looking at the atrial septal aneurysm. So as you know, there's always complications with procedures. So in this procedure specifically, their complications are AFib, and it's up to 4.6% risk of AFib. And in many of these cases, AFib was actually a transient phenomenon. There's, and this, the closed trial published this, and they had only 1 case of atrial flutter and 2 of ventricular tachycardia, air embolism. And this is a stroke, 2021 stroke guideline. So for ESUS, they include this table here saying there's no benefit to anticoagulate ESUS patients. It's not recommended to anticoagulate patients who have ESUS. And there's no benefit on using ticagrelor. This is specifically defined in the new guideline. And looking at the stroke prevention recommendations in terms of PFO, there are new recommendations few weeks ago. And the first recommendation here is saying that the PFO closure have to be done in a jointly fashion with cardiology and trying to take into account the probability of a causal role for PFO. And and they define patients should be between 18 to 60 years of age with non-lacunar ischemic stroke of undetermined cause, despite thorough evaluation, and a PFO with a high-risk anatomical features. And it's reasonable, so it's reasonable to close this PFO with a transcatheter device. They actually include this flow chart in the guideline, which I find interesting and useful. So a young patient between 18 and 60 years of age presenting with an embolic stroke and PFO. So the first thing you need to do is you have to do a complete evaluation. So the evaluation is suggested here, including Dopplers of the upper and lower limbs and pelvic MRVs. And we already discussed this earlier on. And if there was no etiology defined, then you move on forward to a potential paradoxical embolism. So then you have to evaluate that the patient have an atrial septal aneurysm or large right to left shunt. So this is the anatomical high risk feature that the patients have to be able to say that he has a high risk PFO. And in such case, high risk PFO closure is reasonable. However, there is still factors that you might want to take into consideration, like looking at the ROPE score or looking at the patient requires anticoagulation. And even if the patient have a PFO but doesn't have the high risk features, you can still try to, PFO closure is not well established. The benefit of it is not well established. However, you can always look at the risk by looking at the ROPE score, history of DVT, recurrent stroke. So in conclusion, I'd like to say cryptogenic stroke is a very common diagnosis after a stroke. Complete workup is necessary. And therapy is currently with antiplatelet unless specific etiology was identified. Prolonged cardiac monitoring, increased rates of detecting atrial fibrillation, and atrial cardiopathy as a potential risk factor for ESUS. And PFO closure is reasonable in the age of between 18 to 60 years old with patients who have ESUS, PFO with a high risk anatomical features, and trying to develop like a causal association and jointly with cardiology. Thank you. And at the end, I'd like to take this opportunity to invite everybody to Abu Dhabi Brain Conference, which will take place online from the 2nd to the 4th of September of this year. Thank you.